Awesome. Thanks so much, Amanda. And let me share my screen. Hopefully that looks okay. Um, Again, nice small group today. So, feel free to jump in and ask questions if you have any along the way. Or hopefully there will be time for questions at the end as well. But again, good afternoon now, everyone. My name is Adam Novak, Director of Safety and Quality at the Keystone Center. I help to oversee our patient safety organization, but also workforce safety efforts within the MHA as well. So that's what we're going to be talking about today, specifically workplace violence. We do look at a number of types of staff injuries, but workplace violence is a big one, area of high interest. Obviously, you probably know that already, preaching to the choir here. But I'd like to start out with just some general data, and this data chart and this source, and you'll notice too the lower left-hand side of a lot of the slides has the source linked or the peer-reviewed journal article or research study, whatever it is, linked there. So when you get the slides, you should be able to just click it and go straight to the source. But this is a data slide from the U.S. Bureau of Labor Statistics. It's a frequently cited data point, if you will, but it basically is demonstrating how healthcare staff workforce are disproportionately affected by violence specifically. So you can see here, basically 3/4 of all reported violent injuries, and this data is a little outdated. I'm hoping that Bureau of Labor Statistics will get a updated chart soon, but 2011 to 2018, 3/4 of all violence related harm to workers that was reported was in healthcare. So you can see there's a clear issue here with the healthcare field or industry. And then again, same source, but when we look at the most severe types of those injuries, so these are homicides, these are events that ended in the death of a healthcare worker because of an assailant. And this is specifically looking at the relationship of the assailant and the victim. You can see 29%, so almost a third of those assailants were relatives or domestic partners of the healthcare worker. And then I put in here as well, 15% were perpetrated by a patient and 13.5% by a coworker or associate. And we've done webinars in the past on lateral violence, basically peer-to-peer violence. Obviously, this is an extreme. These are death events, but certainly there's bullying and all kinds of stuff that falls under the umbrella of violence that goes on daily and these microaggressions. So certainly things to think about. It's not always somebody, a visitor or a care partner who's maybe being difficult or acting out or being violent, but it can also come from within. A couple other factoids here, and again, I've linked these sources in the bottom left, but in 2022, Presgani did a study and found that 2 nurses are assaulted every hour in healthcare in the US. So basically, by the time we're done with this meeting from start to finish over the lunch hour, 2 nurses somewhere in the US will have been assaulted. Another study done by National Nurses United, again in 2022, it found that there was a 119% increase in workplace violence against nurses since March 2021. So basically, in the throes of the pandemic, right, during that really awful time when nobody knew what was going on, the pandemic had been going for a while, and it was just mass burnout everywhere, and violence increased. And there's a couple hypotheses behind why that is, but all kind of stemming from the pandemic. And then there's obviously the humanistic cost of violence in the workplace. We'll talk about that in a little more depth here, but there's a monetary cost too when we're looking at this this issue, workplace violence, from that enterprise risk management perspective, that's a big piece as well. And with, money in short supply in healthcare and workforce in short supply in healthcare, nobody can afford to take a hit like that. So $35,000 to $45,000 roughly to replace a nurse, and so that could be because of a physical injury where they physically were unable to work, or on the psychological impact and leaving because of burning out and witnessing these things. This is a data chart of the OSHA recordable incident rate data for violence that we collect from a number of Michigan hospitals. You're all welcome to submit your data to us as well. If you have any questions about that, you can reach out after this webinar. We'd be more than happy to either confirm whether you're submitting data or not, and then certainly help you upload that data into our data system called Key Metrics. But this is looking by year, dating back to 2017, the recordable incident rate for workplace violence. And the recordable incident rate is an OSHA standardized metric, which is basically number of incidents per 100 full-time staff. And you can see the how the rate is calculated up in the title there. But what this is demonstrating is, you can see 2020 was kind of a fluke year. There was a lot of underreporting, as you know, with the pandemic just blowing up in 2020. A lot of things had to be put on hold. So there is a denominator issue there, just to point that out. But you can see this kind of progressive trend going in the wrong direction. Starting in 2020 to 2021, there was a 13% increase in the incident rate. And then the next year, a 15% increase, and then a 33% increase through the data we have so far in 2023. So again, we're still not back at the rates that we were at pre-pandemic. Those were a bit higher, but we're trending in the wrong direction. Violence is seemingly going up. Again, with the caveat that this is not 100% of Michigan hospitals represented here. There's some gaps in terms of the amount of data that we're receiving, but this is representative of probably 50 hospitals or so. This is looking at the same data, except now it's by month over the course of several years. And I did just point out here again, our workplace violence incident rate for this month in spring 2020 dropped down to 0.05, which is super low, but you can see it's an outlier just due to underreporting because of the pandemic. And again, you can see over the last year or so, it's kind of slowly crept up. And the most recent data that we have, and there is a lag as well to the data being reported to us, but 1.16 is the rate. So that's incidents of violence per 100 full-time staff. And we do know that workplace violence in particular is heavily underreported, especially acts of verbal aggression, which we do categorize as violence, acts of violence and assault on the person, verbally being screamed at, yelled at, put down, swearing, things like that. So we talked a little bit about the data around the physical implications of violence, which is kind of the obvious one. When you think of workplace violence, you think of getting punched or something like that, or kicked. But there's a psychological impact that's just as important, and a lot of times more damaging long-term to healthcare staff. And so I've pulled a couple studies here that were kind of interesting. This one is from the International Journal of Nursing Studies. It was done in 2020, and it found that staff burnout mediated the relationship between workplace violence and negative health outcomes. Basically, what that means is that workplace violence happening, right? So people are getting punched, hit, yelled at. That influenced staff burnout. So that kind of led to staff starting to burn out, which then led to negative health outcomes for those staff. Things in this research article cited were musculoskeletal injuries actually increased, due to burnout, and burnout was increasing due to workplace violence. So you can see that relationship. There were more anxiety disorders among staff and sleep problems. And this all leads to, the direct impact being on the staff member themselves, but it also influences patient safety, because if you're not healthy and well physically and mentally and psychologically, you can't render the safest, highest quality care possible. And another study, this one's in the journal Frontiers in Psychology in 2022. This one's really interesting. It found that healthcare workers post violent incident, regardless of whether you were physically involved in it or if you just witnessed it or were aware of it, had an impact on staff members that exhibited basically PTSD-like symptoms. So in this diagram at the bottom here, workplace violence awareness. So it's not an awareness campaign or something. It's not good awareness. It's just you're aware that somebody was hit on the unit next to you, or you saw somebody get yelled at in the ED. Just having awareness that these violent incidents are happening in my workplace to my colleagues raise the perception of risk. That sounds pretty normal. When you see it happening to other people, you start thinking, oh, it could happen to me. I could be next. And as that perceived risk increased, staff started experiencing and reporting PTSD-like symptoms, even just from watching it or being aware of it, not even being physically hurt yourself. And so what they found is after these violent incidents, roughly 25% of staff experienced PTSD, 27% experienced anxiety, and 46% experienced depression. So this is diagnosable. So the impact of violence goes well beyond just the physical consequences. And then I did want to throw in just a quick slide on safety culture and kind of all that out. If I back up a couple slides, so when we think of staff burnout here, how that mediated the relationship between workplace violence and negative health outcomes, manifesting physically in staff. If you just look at kind of the top row in the middle, that middle diagram, burnout climate. So I know it's probably tough to read, but the survey item says people in this work setting are burned out from their work. And 58%, the red part of that circular diagram, 58% of people, almost 6 out of 10, said that they agreed or strongly agreed that people in this work setting are burned out from their work. So that's not a good sign when 60% of people are burning out. And that can be due to a lot of things, pandemic stressors and different things, but it's all interwoven. So if you remember, again, burnout led to worse health outcomes. Violence can influence burnout. I think there's a lot going on here that's related culturally as well. So I just wanted to call that out. And then there's also the cost of different types of staff harm. So we're actually working with Blue Cross Blue Shield of Michigan to address a few scopes of work, things like opioids, maternal health, but a third of the funding they're providing is going toward addressing staff safety. So you can see on the left-hand column the different types of harm that we focus on within our programming. And violence, I just wanted to call out here, even though, and this is 2019, our chosen baseline data, 0.44, so that's 0.44 violent incidents per 100 full-time staff in 2019, as reported to us by Michigan hospitals. That sounds low, but again, with the caveat, we do know that violence is heavily underreported. A lot of people feel, unfortunately, still that it's just part of the job. And, oh, it's the sweet old lady who is senile and clawed me and scratched me or slapped me. But that's a recordable incident that should be recorded and not tolerated. Staff need to be physically and mentally safe in their surroundings and not leaving work worse off than when they came in. But that being said, so with that caveat, we also pulled together data on the monetary costs, direct and indirect costs of these various types of harm. And you can see that a violent incident, roughly, and this is a recordable incident rate cost, so it's a rate cost, but $1,400 roughly is the interpretation here. On average, in Michigan hospitals, they spend roughly $1,400 per 100 staff because of violence. So, it's certainly, again, back to the old statement about, we can't afford to lose staff and we can't afford to pay more money basically because of anything. Everybody's trying to slim down. And so this is kind of a double whammy, if you will, just further reinforcing how important it is to address it. And then I did want to mention, and a lot of you are probably familiar, but if you are accredited through the Joint Commission, they did release, I think it was a couple years ago or 3 years ago, maybe. It wasn't too long ago, some updated workplace violence standards. And so I've linked it again in the lower left to the actual source if you're unfamiliar with these and want to go look at them. But basically just highlighted on the next 2 slides what that entails. So just to run through these, the hospital conducts an annual worksite analysis related to workplace violence prevention programming. It establishes a process for continually monitoring and reporting and investigating the following. And so, it goes into injuries to patients or others, illnesses, staff injuries, things of that sort. And then based on those processes, reporting and investigating, safety and security incidents. So it's kind of similar, and I'll talk a little bit about some of the ways you can do that in terms of assessments and different resources that are available to you. And then to round it out, the hospital has a workplace violence prevention program led by designated individuals. So there's an element of accountability in there, having to designate somebody and having it be put together and reviewed by a multidisciplinary team. And then finally, as part of its workplace violence prevention program, the hospital provides training, education, and resources, and this is important here too, at the time of hire and annually, and anytime changes are made to the program, new education has to come out. So this is all encompassing the workplace violence prevention program. And there's a lot of great resources out there that can help you get started down this path if you don't have program, or if you're reviewing it and updating it. There's a lot of great resources out there to help you with that. Okay, so what has the Keystone Center and the MHA done? I mentioned the partnership with Blue Cross Blue Shield of Michigan. They're providing us funding. And about a third of that is going toward workplace safety. And within workplace safety, workplace violence is an area where we're really trying to focus on. But what have we done, in the last couple of years, and specifically more so over the last year, and then currently this year, this program year, we work on a fiscal year. And then in the future, what kind of does that look like? So one of the things we're currently doing is working with an organization called Healthcare Safety Services. And again, I've linked their website below. And some of you may be familiar with Ken Smith and his wife, Joy Smith. So that's their team. Joy is a nurse, and Ken has extensive experience running system level security work at different hospitals, and specifically a system out in Colorado. So they have a wealth of experience, and they're conducting these workplace violence gap analyses. So what does that mean? It basically means they go into hospitals and they look at, the workplace violence prevention committee or team, or if there isn't one, that would be identified in the gap, and how do you get that up and running? It looks more heavily at cultural implications of workplace violence. So we talked about looking at culture results. We talked about, what is the vibe? What is the norm at the organization? Is it normal? Is it a given that, oh, I'm going to go into work and get scratched and slapped and yelled at? Or is that not tolerated? Are there resources and support networks within the hospital or healthcare system that lend themselves to that? So they look at culture, they interview staff, they interview leadership, they walk the hospital grounds, they try to get an idea of that culture. And there's, again, similarly strong focus on people behavior and safety. So going back to culture, is this common? Are people burned out? Is there a good response and support system if a violent incident does occur? And is that support offered not only to the individual who it happened to, but maybe others who could have witnessed it, when we think about that psychological damaging aspect of workplace violence. And again, I did highlight the Joint Commission standards because they do, when they do these gap analyses, that's the lens they're looking through. So if you're a Joint Commission accredited hospital, that would be even more relevant to you. And again, I just threw in de-escalation strategies. That's just one thing that could come out of the gap analysis in terms of a recommendation, for instance. We've also worked with, in the past and currently this year, with a company called HSS. They're an endorsed business partner of the MHA, and they do de-escalation trainings. They do active shooter. They do anything specific to healthcare, workplace violence stuff. And so they're a national corporation. But again, we've been working with them for a couple of years. We'll continue to do so. So last year, we offered physical security risk assessments, which are similar to, but complementary, not intended to be duplicative of the gap analyses that we looked at on the previous slide. So the physical security risk assessments look more at the physical environment of the organization, both inside the hospital itself, the walls of the hospital, and outside in the grounds and the other areas of the campus, or parking garages, parking lots. They look at lighting. They look at, do you have video cameras available? Do you have, what is the pathway that visitors take when they come in and check into the ED? Is there plexiglass? Is there a physical barrier? Or are nursing stations exposed? Somebody could sneak up behind you. And so they incorporate all of this into their report. So it's more focused on the physical security, not as much the culture. And again, it's kind of neat. They look at the area crime report. So they do an analysis of your actual geographic region. Is it a high crime area? Is it low crime? Are you rural? Are you urban, etc.? So we conducted those with 5 hospitals last year, and it sounds like it went really well. The feedback we've received is that there's things nobody even thinks of that came out in the report. Stuff like your bushes outside the building shouldn't be more than 6 feet long and 3 feet tall or something, to minimize the risk of somebody hiding behind it and ambushing someone. And again, going back to that Bureau of Labor Statistics data slide on homicides, even though that is rare and the most severe type of violence against staff, but a third of those were perpetrated by a domestic partner or a relative of that healthcare worker. So they could easily, the wheels start turning. I mean, if they know what time they clock in and clock out, they could be hiding behind a bush or a wall or something. So these are all just little things that kind of come up when you do assessments like this. And going back to Joint Commission standards, doing this regularly is really what you're supposed to be doing. And another thing, I'm really excited about this one that we're doing this year with HSS, is bringing active shooter training to MHA, to the membership. So we're attacking this in 2 different ways. We're going to do large scale virtual trainings. The cool thing about these, so it would be a 1-hour webinar, but the cool thing that we're coordinating with HSS is offering these webinar trainings specifically for individual hospitals or health systems. So what that would mean is, Mackenzie would get their own 1 hour dedicated training just for Mackenzie staff, and McLaren would get one for McLaren staff, or if they wanted to do it by McLaren Greater Lansing or something. So you kind of get the idea. And the neat thing about that is that it allows HSS and the facilitators to sort of tailor some of the information a little bit to make it more relevant to you. So again, are you in a rural setting? What do your resources look like? Are you urban? There's different kinds of threats in different areas, and depending on different geographic locations and communities that you serve. So that's kind of cool. And then the other thing is providing a limited number of targeted in-person simulations. And so this one sounds really interesting to me, but basically what they would do is HSS would send 3 people on site to our HSS staff as observers and documenting and taking notes. And then they provide a report and they debrief with you and staff and leadership afterwards. And then 1 paid actor as the quote unquote aggressor. And so they're basically trying to elicit a physical response from staff. And I can't remember if it was Brian Urich out of Michigan Medicine. He also does active shooter trainings, different things. I can't remember what the actual quote is, but it's something like the body won't go to where the mind hasn't gone, or maybe it's the mind won't go to where the body hasn't gone. Basically, his point is you have to train on this. You have to physically build in muscle memory. Otherwise, when someone walks into the hospital with a gun or a knife, you're just going to freeze. And that's what happens. And that's what what they've told us throughout, doing hundreds of these throughout the country, is that's what happens. Even during these simulations, people freeze, even though it's fake. But the paid actor, the aggressor, will have a dummy airsoft pistol with a little CO2 cartridge in it. So when you pull the trigger, it makes a snapping sound. It doesn't shoot anything out, and they never point it at people. It's always down in the ground or up in the air. But again, it's supposed to kind of simulate, a live event. And so the aggressor comes in and they have different scenarios, but maybe they're talking with a nurse and they're starting to escalate a little bit. And, there's little signs. They're starting to get a little louder, to fidget, to get a little terse, things like that. And then it hits a point where they pull out the fake gun. And then you see how everybody responds. And the one thing that's interesting that HSS has told me, and it almost never fails, is that during these scenarios, there's almost always somebody, even after the aggressor actor pulls out the weapon, there's almost always a nurse or somebody who's still trying to reason with them, who's still trying to talk them down. And HSS teads the run, hide, fight method, which is pretty common. I think we've all heard of that. And so you should have been long gone, when they pulled out a gun. So these are things they document and they talk through with staff. And then you'll notice it says up to 6 sessions within 9 hours. So what they'll do is go from unit to unit. They'll be on one unit, do the simulation, talk with the staff, etc., then go to the next unit. And so that's why they could do 6 sessions, or it doesn't have to be a unit, could be any place, the cafeteria, anywhere you choose. And so these are limited opportunities, but if you're interested in this, please do reach out to me. This is paid for through Blue Cross. Again, it's limited. We can't do these for every single hospital in the state, but we can work to figure out how to best provide these services, and maybe we could do a couple membership wide webinar trainings and things like that too. And then I did want to mention as well that we have current resources that are fully available to all of you. So we have workplace violence prevention posters that you can order free of charge in, I think it's increments of 10, and there's 2 different sizes and of these, but our graphics department, our print shop in-house at MHA, will actually print these off, nice big glossy professional looking posters, and send them to you. And so you can see there's a huge array of diverse types of posters trying to represent all communities. So you can go in and you can put, if you, again, this is linked in the slides, you can click that order form and just go in and say, you know, I want 20 of these and 50 of these and 10 of these. And we'll just fill the order and ship them to whatever shipping address you put in there. So again, free to all MHA members. Just go ahead and click that order form and start ordering. And I've seen a number of these just doing hospital visits, a number of these posters or posters like it. A lot of hospitals create their own, and you know, this has the MHA logo on it. So a lot of times hospitals want their logo, etc. But I see a lot of these types of posters hanging on the walls in hospitals, in waiting rooms and stuff. So that is a resource currently available to you. And another one, and some of you might be familiar with this, that speaks more to the psychological safety and well-being and resilience side of the equation is WellBe. So it's a program called WellBe. We've been partnering over the last, I want to say, almost 2 years now with Dr. Brian Sexton out of Duke University. He's sort of famous for the 3 good things research and work. And so he is offering his staff well-being and resilience program free of charge to any Michigan healthcare worker. So I believe I sent the actual PDF copy of the flyer you see on the right to Amanda. So hopefully that can be distributed to everybody. But this is just a screenshot of it on the right, and it gives you an idea of some of the topics that are covered within this WellBe series. It's actually ending next month, and it's been going for a full year. So it started last October, November, and it's ending in about a month. But the cool thing is, so it was one 1-hour webinar a month for 12 months. And the nice thing is that even though it's pretty much completely over, at this point, you can still click the link or scan that QR code, register, and go back and watch every single one of the previous recordings, access all of the free tools. Each one of these each one of these sessions has a free tool that Duke created, whether it's a journaling tool or something else to assess your level of burnout, let's say, or something like that. And you can still claim CEs for all 12 of these previous ones, or 11 of the previous ones. So each one has nursing CEs as well as medical CMEs available, and you can still claim those by watching the recording. So 12 easy credit hours for you there. And the cool thing too, I think on the next slide, the even better thing, so it's free, but the better thing is that this is rooted in research. It is proven to be effective. So we did basically a pilot of this program over 10 weeks instead of 12 months. It was 10 weeks, almost the same content, with about 5,000 Michigan healthcare staff members. And Duke administered a pre-test and post-test to assess emotional exhaustion, which is basically another way of saying burnout. What they found is that the individuals who made it all the way through the program, right? So they went through all 10, 11 weeks of this program, weekly 1-hour webinars, same content as the 12-month one that's concluding soon. They found a decrease, a 20-point decrease in emotional exhaustion, which is insane. When I was talking with Brian Sexton after these results came out, they were hoping, it sounded like, for 5%, maybe 10% would have been a huge victory. So just blown away when it came back 20 points better. And there was also a relationship or an association between the number of webinars you attended and the magnitude of improvement in emotional exhaustion, basically meaning that those who just went to 3 sessions got a little bit of improvement. Those who went to 5, a little more. Those who did all 10 or 11 had the most profound improvement in emotional exhaustion. So sticking with it is important. But the other thing too that Brian always mentions and this goes back to the three good things idea, is that the well-being improvement, so the improvement in emotional exhaustion that you're seeing here and that they've been able to replicate in years past, is comparable, if not almost better, having longer lasting positive effects as medication, as antidepressants and things like that. So this is a a non-medical way of building resilience and improving your well-being and your work-life balance, and all these topics are covered within the program. So it's well worth it if you're interested, excuse me, or if you know anybody at your organization who's interested in signing up for this. So again, this is the flyer. We can send the actual flyer out, but all you have to do is scan that QR code, or there's actually, it's really hard to see, but there is a link. It's called a bit.ly link, bit.ly, a bit.ly link, where you can click on that and go sign up and access all of this great material. So that was really most of what I had today. It looks like we do have plenty of time left. I see there's a lot of chat stuff going on. So I'll take a look at that. But I did want to, and certainly happy to answer any questions about any of the content covered today. But also, if anybody's willing to share or engage in a discussion, I just thought of these three questions that you can think about and mull over. And if you're willing to provide your experiences with this or what's going on at your organization, that would be great. But basically, what's your biggest area of concern with workplace violence? What actions are you taking or planning to take at your organization to address it? And, what are you hearing from staff? So again, keeping those open lines of communication. I know you're obviously tracking incidents at your organization and hopefully doing debriefing and follow up with those staff members. But hopefully also looking at your culture survey results and just doing walk rounds, just asking, having your finger on the pulse of, are people, is there a sense of dread when they come into work? Are they scared? Are, staff, because I've heard it all. I've heard that, directors of security and whatnot at hospitals are just painting the stark, horrible picture that, oh yeah, we had a nurse just get his lights punched out in the ED yesterday, and somebody else quit, and they're scared to come in, and somebody's getting beat up every week, somewhere around the hospital. And so it's a really scary thing. But I'll just pause there. I'll take a peek at the chat, and certainly Amanda, if you have anything else.
No, I don't have anything additional to add. Thank you for a great presentation. We'll, I guess, open this up to any questions that our members have, or anything that they'd like to share in regards to workplace violence in their facility, or what they're doing, or if they'd like to share.
I have something, if it's okay. This is Heather Strag, Heather from Eaton Rapids. And we had an event, I guess I will say, actually from last week. So it's very timely. And really, it's been, excuse me, weighing on my mind. So obviously we're a critical access hospital, and we don't have security. We, our police force at any given time has 2 officers. Overnight could be less, just depends, because they're struggling just like everyone else. And this particular evening, it was around 11:30 p.m. And the staff at that, oh, sorry, could you hear that? It was like giving feedback on my end. The staff at the particular time was a female physician who is older. I mean, it just is how it is, and very petite lady, older and seasoned, let's say, and 2 female nurses. and we get a call from the EMTs that there's a disgruntled patient that is restrained both physically and chemically, that it's taking all of their manpower in the back of the rig to, you know, kind of manage this patient. They're escorted by police, you know, both local police as well as Michigan State Police. You know, it was kind of like all hands on deck. I listened to the call because of course they're recorded, and there was not a good exchange on the call. Anyways, there was various breakdowns there, but my concern is when they got here, you know, how are we to manage this when there's, I mean, it's just so hard. I mean, we've got female staff. We're already struggling with staffing, and then just trying to staff, like it shouldn't matter if there's female staff or not, or male staff, but then it's hard enough trying to staff everybody, especially at night, and then, you know, rotating like men or women, and then, you know, men shouldn't have to worry about like, oh geez, I'm the male nurse tonight, so now I have to deal with the combative patient. I mean, on the call, the EMT says the guy is, you know, I mean, he's out of breath. You can hear the EMT out of breath on the call, and he's saying, we've got him restrained both physically and chemically. You know, I just gave him, you know, Versed, and he says he's strong as hell. That was his quotes, strong as hell. And the poor nurse, I shouldn't say poor nurse, but she says, we have 2 female nurses and a female doc. Like, you can hear almost like the panic in her voice. And then I watched all the video, and they show up, and I mean, it was just like chaos. And our doc says, bring him in, but I need a cop to stay with us. I need a cop to stay with us. Well, they leave, you know, and it's horrible position to have our staff and anyone to stay in. And I don't care if it's a male doc and 2 male nurses. They're not trained for that. And then I have a conversation with our chief of police, who calls me the next day, you know, ready to rip into me about our staff. And then he laughs at me when I said, our doc asked for a police officer to stay because our staff weren't safe. The patient wasn't safe. I mean, it was all around not a safe situation. We're not equipped for this. Well, then we risk an EMTALA violation if we say we can't handle this. Because let me tell you, the EMTs were ready to hang us up to dry, arguing with our doctor saying, well, you're refusing the patient. And she said, no, I'm not refusing the patient. I just need a police officer to stay for the safety of everyone. I mean, you've come right out. It's all documented that this patient is a threat. I mean, it was a horrible situation. And my chief of police laughed at me when I said our doctor needed a police officer to stay for safety. I mean, it's been weighing on my mind so heavily. Like, what do we do? I go to our admin team and say, we need security. And I'm faced with, well, if you want a security guard, then what nurse are you getting rid of? What radiology tech are you getting rid of? What lab tech are you getting rid of? Are you going to get rid of yourself, Heather? I mean, this is real life situation. So I don't know, like, if you have advice, Adam, Amanda, peers on the call, this is real life daily stuff we're dealing with. And it just happened last weekend. It'll happen again. It'll keep happening. I mean, and even the police officer said, the EMT said, all right, we'll take them down the road to the next one. Well, the next hospital, you all know where I'm at. The next one is another critical access hospital 15 minutes down the road. And the police officer said, they're not equipped to handle it either. You need to go to Lansing. It's horrible. It's horrible.
Wow. Thanks for sharing, Heather. I'm really sorry that happened and that you got that response from law enforcement. I mean, it's always my hope that somehow they can better coordinate with hospitals, but I mean, it sounds like, you know, I will say I've never heard of them, the chief of police laughing at something like that. That's just horrible
Yeah,
and
he laughed at me.
inappropriate.
He laughed and
Yep.
he said, ha ha ha, it was one of my female officers that took him down. And I said, yeah, a female officer who's had police officer training and had a
Yeah,
weapon on her. Our doctors and nurses and any staff here for that matter are not trained like a police officer,
right,
not tackling patients to the ground for Pete's sake.
right. And in this situation too, de-escalation is not going to help you. You know, the
Right,
situation is pre-escalated
right.
and ready for you. And so it's you know, the de-escalation training is not going to help. And it sounds like they're barely able to restrain this individual anyway.
Uh-huh.
So what a
Mhm.
horrible,
Right.
horrible encounter.
It was so bad. And to be honest, even if it was a day shift, I don't know that our hospital would have been prepared.
Right.
Oh,
Absolutely. Well, yeah, let's connect. And certainly anybody else on the line afterwards, if you're interested in any of those offerings, such as, you know, the gap analysis or active shooter training, things like that. HSS also does do de-escalation training. So again, in the situation you described, it wouldn't have helped, but you know, that's also, I've heard good things about organizations who bring people in to do de-escalation training.
yeah. I don't look in the chat. There's so many people that have had the same situations.
Yeah. Not allowed to touch a patient, even if they're actively being aggressive.
Yeah.
Wow.
We had that, Heather, at our hospital too, another critical access.
Uh-huh.
And we ended up afterwards, it wasn't an exact scenario, but it's similar with when do the police stay? When do they
Uh-huh.
leave?
Mhm.
What's the moral obligation there, I guess? We ended up having a meeting with, we invited multiple areas, the chief of police, I think of our town. We invited the local sheriff and some others, and it ended up being the sheriff who was helped implement more assistance because yeah, we don't have security, we don't have
Uh-huh.
those scenarios. It's just like you said, it's either them or we get rid of current staff, and obviously nothing
Right.
is the best, but
Right.
it took a couple big meetings and it wasn't that they're not supportive, but they also have to support the community.
Right.
So how long do they stay at the hospital to
Mhm.
support us while neglecting per se the community and vice versa? Because yeah, if we have one person that's patrolling our town,
Mhm.
we're in a good spot. Usually it's not necessarily that way.
Right.
So I feel your pain, Heather, and
Mhm.
I can definitely empathize with your situation.
Yes, Alicia, it's crazy.
It is.
Mhm.
It's very strenuous.
Yes. And to be honest, I was happy to hear that they were even here in the first place because it was a Friday night. They could have been anywhere around town.
Right. Yeah, and we usually don't have many officers on at night, so we would have either a county or a state person, which could be up to an hour away. So having
Mhm.
police as backup isn't always the best go-to, but thankfully we own our own EMS system and we have that support. So if they're around, they're in our ER to provide support.
Oh, that's great.
This is Tiffany. I'm just going to add another perspective as well. When we talk about EMS showing up at our front door to bring us patients, we also have to remember, unfortunately, they also have rules and regs that they have to abide by in their MCAs. And so when we talk about what is the closest facility, may not be the best fit facility, but based on criteria of the patient, sometimes the closest facility is the first facility they have to stop at. And it goes back to also reimbursement. So there's a lot of times if the first facility isn't the best facility and they have to move on to a second facility or even a third facility, there may not be reimbursement for those emergency calls too. So there is a lot. We own an EMS agency as well. And so I do a lot of the regulatory piece for EMS and billing. So there's a lot of education that has to go to the MCA, that we have to do with hospitals, that we have to do with EMS for the understanding of how do we refuse a patient without having it entail a violation? How do you still get reimbursement for that? So I know there's a lot that goes into safety, but it's also the rules and regs that follow the emergency departments and the EMS organizations as well. It is difficult and it is a fine line that we run every day.
Yeah.
I'll just jump in and give a quick scenario of what we had happen here 2 weeks ago. There were a couple of minors who were truants and having some kind of a visit by CMH when they became very violent. And so police were called, I don't think EMS was called. They brought them here, even though there was another hospital that was closer. So there's something that we're working on. But these two individuals, although they had calmed down when they got here and law enforcement left, and we are very fortunate to have law enforcement that does support us here, but they flipped in the matter of 1 second. And they said all of a sudden their eyes were wild. And this was at 9 o'clock at night. We had 3 nurses here, a lab tech, a housekeeping person, and a registration person, all females. And so they broke out of the ER. There's a sliding glass door. They pushed that open and broke a piece off of that and ran outside. And so they were so violent that we had to make a decision. And we did a modified lockdown because they couldn't come back in for the threats that they had made to the nurses. So that I'm a risk manager, and that's a huge risk for us because those patients are our liability once they leave this building like that out of control. But our staff safety was important. And so, we had a team call right then and supported the lockdown. And it turns out that the guys were only gone for a few minutes because when they went to leave, they dropped their gown off, they took their blanket off, and they ran out in their underwear. And it was pretty cold that night. So they eventually came back because they were wanting to get back in. But we've had a meeting with our court system, with mental health, with juvie, and we continue to work with them on some of our mental health patients. And in this situation, it was just extremely difficult because mom didn't want them back. They wanted to send one back with a safety plan. So we eventually got that one to go home with the grandma. The other one, it took another day and a half to get placed, but all during that time, you're on that high alert, and it's, you're right, Heather, there's a skeleton crew here, especially at night. So
Yeah.
You never know. And when they're throwing knives, it gets a little scary.
Oh, gosh. You have doozies up there, Jen.
Yeah, I know.
Oh, my goodness.
I'm curious, real quick. I know we have just a few minutes left, but how is it going with reporting? So reporting acts of violence, do you find that staff are hesitant to report, or do they not understand what should be reported? Because again, a lot of times it's like, oh, someone yelled at me, I'm not going to go fill out a report for that. I'm just going to carry on with my day because I don't have time.
We have a hard time up here. I live in the UP, so people don't really know what to report, and we try to explain to them, myself and our other safety officer, that they can call us during whenever, if they're having a situation, and the two of us can kind of play off each other depending on who the patient is. But he and I work real well as a team. We do have great law enforcement backup, but a lot of people just they don't think that they need to report it because they've gotten to the point that, well, this is just how we're treated. It's not right, but it's how we're treated. And we're trying to change that mindset with our staff.
And it looks like that's what's being shared in the chat as well. Just, not a lot of reporting. It's just being normalized. Huge cultural component to it for sure. All right, I don't know if there's any other questions, or Amanda, if you have anything additional.
No, I guess what I would point out is I did reach out to Michelle Ropek from Laura, and had asked that sort of the question about workplace violence questions coming from surveys, because I think we had that question come up from one of the strategy group meetings that we had talking about surveys and the questioning of workplace violence. And speaking with Michelle, she said that Laura doesn't routinely ask those questions on their surveys, but definitely could be something where you may start seeing your accreditation agencies talking to you about workplace violence and it being reported. So I think maybe we need to be a little more cognizant that it's going, you may start seeing that coming in from your accreditation surveys and questioning that, and just maybe preparing your staff to know where to report it, how to report it, because it is underreported. It's underreported everywhere, in big hospitals, little hospitals. I think it's just underreported everywhere. But I see Alicia said Joint Commission didn't ask, and so that was in August, that Alicia's saying that they didn't ask at the end of August. So just kind of, even though the Joint Commission didn't ask, I know that there are other accreditation agencies out there. So doesn't mean that it's not going to happen. But underreporting and is definitely a big thing.
I heard a story too, a hospital in Michigan, probably in the last 6 months or so, shared a story about how they were being surveyed. I can't remember who was there, but some survey was going on, and the hospital was dinged. They were penalized because as these surveyors were talking with staff, it came out that the staff member didn't report a physical act of something, violence, or maybe it was somebody yelling or swearing at them, and they didn't report it because they didn't know that they were supposed to report it. They didn't think it was report worthy, and the hospital didn't know that this happened and that the staff member didn't report it, but it was all coming out right in front of the surveyor, and they dinged them for it. So it's like you can't win half the time. So I completely echo your remarks about just always trying to do your due diligence and be as prepared as possible.
Are there any final questions before we end today's call? Well, Adam, thank you so much for joining us today. It was very insightful. I appreciate you taking the time to meet with us. If anyone has any questions that you want to get back to Adam, you can reach out to me or reach out to Adam directly. And again, thank you so much for taking your time with us today. I appreciate it.
Absolutely. And thank you for organizing, and thanks everyone for spending your lunch hour with me.
All right. Thanks, everybody. Have a great
Thank you.
afternoon.
Have a great
Take
day.
care.
Yeah, bye-bye.
Bye.